The skull has three components: brain tissue, blood, and CSF. And basically, it's all of those forces that are within the brain that really make you question whether a patient is having increased intracranial pressure. So even if you hadn't read anything, even if you hadn't done any of the notes, in your just normal day-to-day life, if you had something really pressing on your brain, pressing on your head, what would be some of the symptoms that you would have?
Headache.
Headache, right? Nausea, vomiting.
Positive altered motor function.
Yep, positive altered motor function. What else?
Visual acuity issues.
Yeah, visual acuity issues. What about all these bright lights? Okay.
Sensitivity to stimulus.
Yeah, sensitivity to light. Who's ever had migraines? Okay. Horrible, right? Put yourself in your shoes just like that, but 10 times worse. Okay. Those are kind of some of the symptoms that you would be seeing with increased intracranial pressure if you had it or if your patient had it. So really, there's three different kinds of things that we're going to be looking at with this, okay? What I'm going to do is just really kind of get down to the bare bones of it, okay? So within the increased intracranial pressure, you have forces measured in the brain, okay? So you have all these different components that are in the brain. And it's really the balance between the brain, the blood, and the CSF fluid that is all making things kind of work in balance, okay? So if we kind of look all the way down to the bottom, factors that influence ICP under normal circumstances. So you have the arterial pressure and the venous pressures, right? Okay, that kind of sums up blood pressures, okay? So why would you think that an increase in intra-abdominal pressure or intrathoracic pressure would have a relation to changing increased intracranial pressure? So let me put it a different way. So let's just say you have, to have a bowel movement, right? Okay. What do you do when you have a bowel movement? Not all the details, but okay. Right. So, what's that? I probably don't want to know that. Okay.
No, I was being serious. Like, you're talking about like the tightening of the abdominal muscles,
Yes.
bearing down.
Yes. Yes.
Blood into your head.
Exactly right. So you're bearing down, right? You're putting all that pressure. Okay. So that pressure corresponds with you actually increasing intracranial pressure. Okay. As we kind of get through here, I want you to think about, okay, I've got this migraine, okay? Think of it as a migraine. Think of it as increased intracranial pressure. What would be the kinds of things that you would feel if you were a patient experiencing that, okay? So, if you're trying to have a bowel movement, you're having that pressure, okay? What are you going to be doing to alleviate somebody that is trying to have a bowel movement that's really having some difficulty? What kind of medication would you give? Stool softeners, right? Okay? So I want you to kind of think, I think this is the best way to think about intracranial pressure. Just think of the steps. Think of the pressure, think of what's happening in the body, think of what you can do as a nurse to reduce it, to alleviate some of the issues that are surrounding it, okay? What about if you are somebody that's really, really obese, okay? What kinds of things do you think that's going to happen with pressure in the body? If they're trying to breathe, if they're just really, really working hard, you're going to have that diaphragmatic pressure, okay? Everything is just, what I'm trying to get at is everything in the body is forcing this pressure to go up, okay? If you have somebody that has multiple symptoms, okay? So what would you think about I'm going to hold my thought. Okay. Okay. So who's heard of the Monroe-Kelly doctrine? Okay. Victoria, can you tell me about it?
Well, I just read it in the book, but basically, if you have volume of one component increasing, then the other one has to decrease because it has to be like this perfect pie is what I envision it as.
Exactly. Yeah.
Or else you can,
Yeah, that's a perfect explanation for it. So you only have so much space in your brain, right? Okay? If you have one increase in one compartment, the other other side has to decrease kind of to make room for it, right? Okay? So essentially, the Monroe-Kelly doctrine says a volume in one component increases, a volume in another must decrease to maintain intracranial pressure. Okay? Very, very simple. Okay? So let's talk about some basic formulas that you may or may see, okay, and some ranges that you may or may see. Probably going to see them 99% of the time. What is normal ICP? What's that range?
7 to 15.
Pretty close, 5 to 15. Real easy numbers to remember, okay? Once again, you're never gonna have a question that says, hey, is the patient's ICP increasing, and they give you the number of 16, okay? That's not gonna happen, right? It's never gonna be that fine of a line, okay? I just want you to think of 5 to 15, that's normal ICP pressure, okay? So, if you have levels sustained that are less than a particular number, you really start worrying about perfusion. Okay, so this is all about perfusion. So I'm just gonna, who knows the number? If it falls below a certain number, it's just 20.
30 to 50?
Yeah,
You're saying?
30 to 50. Okay,
Yeah.
but definitely if you have a number that's 20 or less, that's what you're saying to yourself. That's severely abnormal. There's not enough perfusion going on to maintain life.
Maybe the pressure's too high and had that blood can't show up.
Well, so if it's too low, right, you're not having that perfusion, right? So if it's less than 20 or less, that's abnormal.
But isn't 5 to 15 normal? So
Oh,
wouldn't
I'm sorry.
5 be
Yes,
okay?
you're right. You're right. So if it's greater than that, then yes, you're correct.
Okay.
Yeah, I'm sorry. I shouldn't have made that video so late last night. Okay, yes, okay, you're correct. Okay, so why do we eat? Basically, we eat so that we can maintain our bodies, right? Okay, I just think this is a really neat fact. 20% of the body, the brain uses 20% of the body's oxygen supply, 25% of it's glucose, and 17% is cardiac output. Okay, you don't need to know those numbers, but I just think it's kind of interesting and explains what happens to you, sort of like just what happened with my brain fart right there, okay? That's why you want to eat before you go to clinicals, especially before you go to the OR. Okay, so these are some formulas that you'll eventually need to know, okay? Cerebral blood flow, but you can do all these numbers until you're blue in the face, but essentially the sentence up on top says it all, okay? The critical parameter for brain function and survival is not ICP, rather it's making sure that you have adequate blood flow, okay? That's really what it's all about. Granted, we have our numbers are always going to be on the screen, and that's what we're on the lookout for, but we want to make sure that we have that perfusion, okay? So what is CPP? Cerebral perfusion pressure. It's the pressure needed to ensure that blood flow, okay? Less than 30 to 50, basically, you have ischemia and death, okay? This is the formula that you'll need to know, okay? Right here. Normal cerebral blood perfusion should be between 60 and 100. So a lot of times you'll see a map on the screen, okay? You'll kind of see it. If you see the vitals and you'll see your blood pressure, right next to the blood pressure, you'll see a map, and it'll say map, and everybody's always wondering, well, what's map? Anybody know what map is?
Mean arterial pressure.
Okay. What is it really? What is it really to you? What's that?
Indication of like blood delivery.
Yeah, I mean, you can think of it that way. Essentially, it's a whole cycle, okay? It's the average arterial pressure throughout one cardiac cycle. So that includes systole and diastole, okay? Basically, what you're looking at is the map. It changes due to certain specific output and vascular resistance. So really, it's all about the output and the resistance. So let's just say you have a map that's less than 70. if your map is severely, severely high? Just incredibly high pressure, right?
Hypertension.
Yeah.
A hypertensive crisis.
Yes, hypertensive crisis, that's a perfect example of it. These are what we're looking at, okay? If you have a decrease in cerebral blood flow, or you have a very high cerebral blood flow, okay? These are just things I want you to think about. Why would you have acidosis with decreased cerebral blood flow?
The cells will be trying to meet their needs of liver, so produce lactic acid.
Well, so they're not, everything is kind of not perfusing the way it should, right? Okay? So it makes sense that you have that residual of the acidosis. Your body's gonna have all that CO2 built out. What about some of the results of the increased intracranial pressure? They're really, really super duper high. What do you think about that? Why would you have that with, say, let's just say you have brain surgery. Why do you think you might have increased cerebral blood flow?
Inflammation from healing.
Yeah, inflammation, that's exactly right, right? These are some of the manifestations that we're gonna be really focusing in on ICP, okay? This lecture is really about increased intracranial pressure. That's what we're gonna focus on primarily from this point forward, okay? So this is pretty basic, okay? These would be some of the changes that you would see with increased intracranial pressure, okay? What about your vital signs? What would you expect? High blood pressure, yep, what else? What's that? I'm sorry, I still can't hear you. Bradycardia, well, so let's talk about, well, we're gonna be talking about Cushing's in just a little bit, okay? So that's kind of getting into Cushing's triad, okay? And we'll talk about that here in just a second. What about blood, body temperature? Increase, right? Okay, so 3, 4, and 6. 3, 4, and 6. Okay, those are the ones I want you to know because those are the ones specifically for increased intracranial pressure. Okay, that has everything to do with the eye movement. As you guys said earlier, headache and vomiting, not necessarily with nausea, but you could. Okay, it's almost like a projectile vomiting before you even know what's happening. So if you have increased intracranial pressure, what do you think would be going on with the level of consciousness? Decreased, right? Right? You've got such a headache and things are just almost going, exploding if you can think of it that way, okay? So you have a change in level of consciousness. That's the most predictable factor of any neurological assessment that you're gonna be doing, okay? I know you keep hearing that over and over and over again. Trust me, if level of consciousness is one of the chooses of the questions, that's what you're gonna pick.
So indicator of neurological status?
Mhm. Yeah, very, very much. So if you have increased intracranial pressure, these are some of the very significant signs that you'll see within the eyes, and this is what you'll be looking for when you're checking for those cranial nerves, okay? So pupil dilation, one could be more dilated than the other, and that's why your flashlights have those little circles on them, right? Because it's really easy for you to tell what things should look like, okay? Sluggish or no response to light, inability to move the eye upward, okay? You could have eye drooping, you could have so much inflammation around the optic nerve that you're gonna have some pressure, and that's what's on the bottom there. Who knows about the doll's eye reflex? Every time I see it, I have to watch a video of it. Anybody know? Good, the bad, the ugly of that? Okay. So essentially, if you can think about it, a positive Dahl's eye reflex is that when your eye, if somebody were to keep your head like this and then move your head, your eye would kind of go in that direction, okay? So basically the eye is moving in that direction. Even, you don't have any control over it. It's just what your eye does, okay? So if you have somebody that, let's just say, has a neurological status of 8, okay? And we'll kind of go into the Glasgow Coma score here in just a minute. 8 basically means that you're gonna intubate pretty darn quick if you haven't already. And if you ever see a patient like that, when you turn their head, nothing happens to their eye movement. It just goes, okay, it just doesn't move, okay? Okay, so a positive Dahl's eye reflex is what you want. That's the good thing. Okay, you guys had this in fundamentals, right? All the posturing, okay, it should be a review to you, okay? We're gonna go more into this when we talk about seizures, because obviously that's what you're going to find most likely with that posturing, okay? Decorticate and decerebrate. This is that Glasgow Coma scale, okay? I'm gonna say this 3 times, okay? Because at some point in time, you guys are going to not remember. The Glasgow Coma score is based on behavior. It's based on behavior, okay? It's not motor specifically, it's not verbal specifically, it's based on behavior. It's a behavior score, okay? All based on behavior, okay? Eye-opening, verbal response, and motor response. Those are the effects of it, but you have to understand it's based on the patient's behavior, okay? So let's just say you come into a room and the patient is sleeping, okay? And you say, hey, Mike, how you doing? Okay? They easily awake, okay? So what would be the response?
Doing good.
Might be a 3, right, to speech, because they were sound asleep. Okay, so their behavior was they responded to you with, hey. Okay, so what about the verbal response? If you go into that room and you say, hey, Mike, do you know where you're at? And he can tell you, obviously it's number 5, okay? All these things are adding up. Motor response. If you ask them to wave, can they wave? Okay? So please make note of this. You will see this forever and ever and ever and ever. This is what you'll see nurses kind of use under the cuff as they're doing their neuro assessments. It's one of the key things. If you have any questions about it, make sure you refer to that page number, okay? I put this picture in here only because it's so gross. This is actually caused from nurses and other providers. They kept going into a patient's room in the ICU. Hey, they were doing a sternal rub, right? You guys are taught how to do sternal rubs, okay? They kept trying to make sure that this patient was not responding, okay? That's what can happen, right? So if your patient doesn't respond the first time, maybe try a second time. Don't do that sternal rub if you don't have to. Okay, so Cushing's triad. Who has heard of Cushing's triad? Okay, it's a little tricky, only because a lot of times students don't quite understand the mechanics of what bradycardia is versus widening pulse pressure, those kinds of things. One thing you want to make sure of that you don't mix up Cushing's triad and Cushing's syndrome. We're not talking about Cushing's syndrome. Okay. So Sarah, you raised your hand. Can you tell me? Do you know what Cushing's triad is, or maybe just a feature of it?
Well, just, I mean, I just know about it because of the reading, but.
Yeah. Okay.
Yeah, I mean, the difference between systolic and diastolic is growing.
Okay.
And then, I mean, it says up there, decreased pulse, decreased respiration.
Yeah. So that's exactly right, but it's a little bit more specific, and I put this just as basic so you guys can kind of have an understanding of it, okay? Number 1, it's a sign that you have increased intracranial pressure, okay? As Sarah had said, the systolic and the diastolic, they're kind of going this way, okay? So you hear the word widening, There's a greater difference between the systolic and the diastolic, okay? That's number one, okay? Number two is decreased pulse. So what's a normal rate for adults, pulse?
60 to 100.
60, okay? 60 is as low as you want to go, okay? If you actually get to bradycardia, which is less than 60, that is your ticket that says, oh my gosh, they're definitely going into Cushing's triad, they're going to go into shock, okay? So there's a difference between just a decreased pulse and bradycardia. Just know that 60 is your number that you're after, okay? Yes?
What about our patients that are often, like our runners and people who are really active and they normally have a pulse that's less than 60?
Yeah.
Are we concerned about that or?
Really good question. You have to ask.
Okay.
Like, we had that in PACU all the time, just to get baseline vitals. Yeah. So Bella asked a really good question. If you have a patient that is an athlete, okay, or is very, very active, oftentimes you will see a pulse that's less than 60, okay? But in a normal hospital setting, okay, and they're laid out on the bed and they're not doing well, 60 is your cutoff, okay? Okay, respiration, yeah.
Is this, when it says irregular respirations, is this like when you start to see Shane Stokes?
Yes, Shane Stokes, yep.
And
Yep.
is this, like, the brain is starting to herniate, like, these are brainstem issues? Yeah?
Yes, yes, increased intracranial pressure, so yeah, that brainstem is just basically getting squished, yeah, yeah.
Can you give an example of the widening from the systolic and the diastolic?
Oh gosh, it could be anything. So you could start out with like 110/20, and then all of a sudden it just gets, the difference between the top and the bottom get even increased.
Mm-hmm.
Let's see, I'm trying to think of a really horrible blood pressure. Go ahead, what's a really bad blood pressure?
210/120.
What is it?
Really bad. 210/120.
Yeah, that would be pretty bad. I was trying to think of something realistic, but yeah. Yeah.
That's realistic.
Yeah. That's really bad. I'll explain the dynamics to you later.
Okay, yes,
Okay?
and also for,
Yeah.
when you talked about, having, less than 60,
Uh-huh.
is that, maybe they're gonna go into bradycardia at some point, or
Well,
no?
so less than 60 is considered bradycardia.
Okay, got it.
Yeah, that's your mark. Yeah. Okay. Respirations, okay? What's going on respiration-wise?
It's a man.
Decreasing.
They're decreasing, right? Okay? Just before they go into shock, things just get even worse, okay? All right. The biggest thing about the respirations, I almost forgot. Asa, you had said irregular,
Yes.
okay? So what is Shane Stokes?
Alternating hyperventilation, hypoventilation in cycle.
Yeah, with apneic episodes, right? That's the thing, right? They're breathing and then they're not. They're breathing, then they're not, that kind of thing, okay? I think I've got a picture, yeah, up here. Right on top, circles of hyperventilation and apnea, okay? It's important that you understand what Shane Stokes is. The others are just kind of gravy, but important that you know that one. Okay, so we've pretty much gone through what you're gonna be doing, what you're looking for when you're doing your neuro assessment. You're gonna be using the Glasgow-Coma scale, and what does that measure again? Behavior, okay? You're gonna be looking at the cranial nerves. If the patient is ambulating, obviously you're gonna be assessing motor strength and gait, okay? Sensory, what can they hear, if anything, if they have their gag reflex, can they taste? You're also checking reflexes. A lot of these things the physicians will do, okay? You see that when they check your knee and you have that reflex, they have that little that little hammer that they use, okay? And then vital signs, including the respiration patterns, right? Because we just talked about it. If you're seeing Shane Stokes, you know that something is very, very dire. Something is very, very wrong. So these are some of the key diagnostics, okay? You're gonna do a CT scan, they can do an ICP measurement, basically, they just drill right into the brain. I'm not sure exactly which spot, it's pretty nasty. Not something that you guys would be participating in, but just so you know. What about a lumbar puncture? Why would you think that we don't wanna do a lumbar puncture, when we're suspecting increased intracranial pressure?
Could it
Herniation.
be like worrying about increased pressure due to like infection or something like that? So they,
Well, so,
The
or-
brain
yes, I
hernia.
mean, anytime you access the skin or whatever, you're always gonna have a risk for infection.
The
But
release
just
of
in
that
the
pressure,
immediate
like,
setting,
all your brain.
what would you be afraid of? Yes.
Does it have to do with the Monroe-Kelly thing of if you were to pull out some of that fluid, then somewhere else could herniate or?
Exactly,
like,
it's
gonna
the
mess with the
release of the
system?
pressure.
They don't learn how to talk
Yeah,
about it.
yeah, can have a horrible release of pressure that could cause the cerebral herniation. Okay, that's why you would never do it if you suspect increase in cranial pressure.
Do we call it cerebral herniation or like a herniation at the puncture site?
Well, I was told that it was the cerebral herniation.
Or cerebral herniation.
This is what it's all about. This is your nursing care for your patients with increased intracranial pressure. These are very specific guidelines, and you see the hospitals really, like, this is what they do. They don't wave their hands, okay? The head of the bed, 30 degrees with head in neutral midline position. Okay, you will see that time and time again. What kinds of focus checks? We've gone through those. What about suctioning, okay? Let's just say you have this patient that is in the ICU, and I don't know if you all have ever spent any time there, if you've had family or whatever the case may be. But obviously when somebody is intubated, they're gonna be doing some oral suctioning, okay? Why would you keep it, if you absolutely had to do it, why is it so important to keep it less than, say, 10 to 15 seconds?
It can further increase pressure.
Yes, essentially, yeah. What do you think it could stimulate? Like if somebody were jamming that in your mouth, what would you think?
Your gag reflex.
You gag, you cough, right? Okay, cough is the last thing you want to happen,
No.
okay? What about you, so you're thinking about yourself, you've got this migraine, okay? You want it loud or quiet? Quiet, okay? So you're gonna keep all the stimuli down to a minimum. Same thing, we're still talking about nursing care, okay? You'll hear the word cluster care, that's exactly what it is. You're clustering all your cares all at the same time as much as you can. You'll do that a lot in the NICU, okay? They use that word like every sentence that comes out of their mouth. So you're always gonna be clustering care, minimizing any stimuli, okay? Fluids, usually we're restricting them, and you also wanna watch the diuretic effect of it. But I'm gonna point out mannitol. Mannitol is what you typically will see as a diuretic if you have a patient that has increased intracranial pressure, okay? I don't wanna get into the details of it, because I kinda spoke with Jameson, and she was like, yeah, don't go too far into mannitol. Just know that mannitol is like a bag of fluid, okay? You'll see it on the floor. It can be mixed in fluid, it can be an individual vial, but essentially what it does, it is a diuretic, okay? So that's what they use when you have increased intracranial pressure. Okay? Also, if you have a patient that's in the ICU, you hear it turning, right? Because they're not moving. You guys know the importance of turning patients and making sure that they're having adequate perfusion to those tissues. So it's really important that you're preventing that skin breakdown. You're doing skin checks, you're doing maybe Q2 turns, so every 2 hours you're turning them. Oral care, we talked about that, because why? What did we just talk about last unit?
Pneumonia.
Pneumonia, right? They can get ventilator-acquired pneumonia if you're not doing adequate oral care. Stool softeners and laxatives, we talked about that earlier. How come?
Intra-abdominal pressure.
Yeah, you don't want to increase that inter-abdominal pressure. So you want to decrease it by giving them stool softeners so they're not having to use that pressure. Okay, they're not pressing down. Treat fever. Okay, that says it all. We all know that when we have a fever, it increases our metabolic rate, okay? And therefore that would increase intracranial pressure. We're gonna buzz through here, okay? So, meningitis. We're gonna switch gears. And the reason why this is on here is because we're talking about increased intracranial pressure, and this is what you will have with this, okay? Depending on how bad it is, okay? Obviously, bacterial is much worse than viral meningitis. Basically, bacterial meningitis is inflammation around the tissue surrounding the brain. So I think, I used to have another slide. So basically, it's in between, okay? So if you can think of it here, it's just within the tissues of the meninges, okay? Obviously, it's a really bad situation. These are some of the manifestations. As nurses, this is going to be the key here. I'm not gonna go into all the big details of everything about meningitis, because I want you to see what you could possibly be presented with in the hospital, okay? So, manifestations of meningitis. There's seems to be a lot of confusion between viral and bacterial in terms of the signs and the symptoms, okay? They're pretty much identical, okay? The big thing is that bacterial is much worse, much worse, and they have the possibility of having much long-term effects, much more horrible things that could happen to them later on, okay? Another, between the two, which one do you give antibiotics to? Bacterial, right? Okay. So I just wanted to throw that out at you. So basically, the manifestations of viral and bacterial meningitis are almost identical, okay? Yes?
I read in the textbook that if it's meningitis, we're starting antibiotics right away, but even before we get our culture back. So is that the case even with the viral, because we're not sure if it's a bacterial or viral yet?
Absolutely.
Okay.
Yeah. If we don't treat them right away, after we've gotten our culture, after we've gotten our samples, think of the worst possible thing that could happen to them. So we'd much rather do that.
Okay,
And you bring up a good point about making sure you have the sample before you get those antibiotics.
And
Yeah.
then would we just stop the antibiotic, if we have verified that it's not a bacterial? Okay.
Yep, that's exactly what they do. Yep. Okay, so manifestations of meningitis. Really high fever, okay? Fever after 2 to 3 days. They have that severe headache. Once again, you have increased intracranial pressure. So if you can think to yourself, okay, these are all the things that are happening. They also have nuchal rigidity. What is that? That just sounds awful.
Neck stiffness.
Your neck is so stiff you can't even move it, okay? Nausea, vomiting, okay? What is that phototopia? Yeah, light sensitivity, right? Okay? Okay. This is actually this rash right here. Petechial rash on the trunk and legs, okay? What is that called? It's like a petechial rash, but if it goes on further, what's sort of like the name that you'll hear? Purpura?
Yeah.
Okay. Okay. You'll have a decreased level of consciousness. We'll talk about the positive Kernigs or Brzezinski's. We've already talked about the increased intracranial pressure. Sure, covered everything. What's that?
What is it called?
Well, it's called petechial rash, which eventually kind of turns into purpura. Okay. So, who's ever heard of these words before? These fancy words. Okay. Basically, if a patient is positive with either one of these, most likely they're going to have a diagnosis of meningitis. However, they're going to do the cultures. Okay, they're not going to just assume just because of this that it's positive. Okay, so So the Brzezinski sign is when you put your neck is flexed by the doctor, and then automatically when the doctor does that, the patient flexes their hip and their knees. It's almost like an automatic response. They don't have any response. They don't have any control over that response. Okay? Kernig's, this is also just named differently. Kernig's is when the doctor is unable to extend the patient's leg at the knee when the thigh is flexed, just due to the total stiffness of the hamstrings. Okay? Hopefully you guys have practiced that because that's part of the Olympics. 2 tests. And believe it or not, I had Brzezinski's on my in class. Some things that seem so like obscure, but yeah. You don't forget those questions. Okay, so I put this in here because this is what happens when you have somebody that has meningitis, bacterial meningitis, and it went untreated for several days, okay? You can lose your arms, your legs, as you can see, she's lost quite a bit there. Diagnostics, okay? CT scan first, do a contrast, why? If they're diabetic and they're on something, metformin, right? How long do you hold it for? Yep, 48 hours before, 48 hours after, okay? Okay. The thing here is that when they get the CSF, if it's not clear, it's not good, okay? Something's going on, or the specimen wasn't taken correctly, okay? Who's ever seen an LP done? Okay, LP, anybody seen an LP? Okay, so can you kind of explain how they do it?
Yeah, so, I mean, I've seen it mostly in the sitting position unless they were a child, and, the doctor is looking for not the actual spinal cord, but the cauda equina, so it's like gonna be the bottom of the thoracic spine, and you flex the back to kind of open up that space so they can better visualize where they're gonna be going in between the vertebrae, and then they have special needles that have the bevel is a little more flat, and they try to go in between, so they turn the needle to go in between
Right in
nerve
that
fibers
space.
instead of cutting across nerve fibers. And sometimes it doesn't happen the first try, like IVs.
Yeah.
It's really terrible, but
How many samples do they get, roughly? Okay, sometimes it's 4, sometimes it's 5. And the reason being is sometimes that initial sample that you get will be bloody, okay? And that's sort of almost like a throwaway, per se, okay? So they'll do multiple vials. The neat thing, I think it's neat, the neat thing about LPs is that when they put that needle in, it's not like you have to suction anything out or put a tourniquet around the body, anything like that. It literally just drips out, okay? So once they have that needle in the space, it's kind of like this long tube, and the CSF literally just trickles out of the tube. And so they just hold the tube right underneath of it, okay? So it's pretty cool. Anyway, yeah, there are a couple different positions. As the nurse, your responsibility would be keeping them like from panicking, obviously, right? Because imagine that needle going in the space, you don't want them moving around, okay? It's a very, very narrow window in terms of where that needle goes, okay? So they're gonna be in the sitting position or they're gonna be lying down, okay? And sometimes, literally, you're just crunched with them. And the important thing, as Asa said, you're actually turning that spine to try to open up that space where that needle goes, okay? So in terms of the CSF, why would you think that the protein would be high if it was bacterial?
Increased capillary permeability.
I'm sorry, what?
Like increased capillary permeability if the protein is getting through the pores for the infection.
Well, what do you think about bacteria? What do you think they like to eat? They think they live off of sugars, okay? So first, let's talk about the glucose, okay? So you think about your bacteria, right? Okay? So we'll kind of hop down just a minute. So let's talk about bacteria. They like to eat what? They like to eat glucose, right? So that's gonna be decreased, okay? What about the neutrophils? What does that tell you? It's infection, right? It's bacterial, okay? What about the protein? Why is that high? And the reason why I skipped it is quite honestly, I can't remember the answer.
Pus is made of protein.
What's that?
Like pus is made of protein. Like dead bacteria are made of protein. Like don't you lose a lot of protein?
Can somebody look it up? Because like I said, it's like, I can't think of why, but it's a very specific reason and it's something you guys need to know. There's something else. Anyone?
During bacterial infection, protein levels in the CSF go up due to the increased number of replicating bacteria and body cells fighting the infection, both of them having high concentrations of protein. High levels of lactate indicate lactate of the bacterial infection.
Okay, let's think there's something else, so I must be totally wrong on that one. But yeah, there you have it. Everybody here, Asa? It's important that you know, I'll remember to remember that. Okay. But it's really important that you remember that bacteria like glucose, they like the sugar, okay? So they're gonna eat it all up. Okay. Nursing care for bacterial meningitis. You guys who know this, the big things here, let's just say, let me give you an example. If you have a patient that has a temperature of, let's just say it's 104, 105, right? And you know that they have meningitis, bacterial meningitis. What is going to trump those antibiotics? Is anything going to trump those antibiotics in terms of what you're going to administer? If they have a temperature of 104, or let's just say they have this horrible pain that they're screaming and yelling at you, and they're calling, they want some sort of pain medication. What would you do first? You've already got your cultures, right? Cultures are A1, okay? Whether you've got it through the CFS, okay, they've done the LP, they've done the lumbar puncture, so you have your samples. Is any medication going to trump your antibiotics if you suspect that somebody has bacterial meningitis? No. Never, never, ever, ever. Okay? Make sure you get the samples first, and then you go straight for your antibiotics. I don't care how high that fever is. I don't care if they're screaming, yelling, bloody murder, because they're in so much pain. Your A1 is your antibiotic if they have bacterial meningitis. And then you're going to be treating the fever, okay? You're going to be treating pain, those kinds of things. Yes?
You said sample first, but I thought you gave the antibiotics first and then got the samples confirmed.
Oh, no, you never do that. Not with this. You don't wait. So the question is, yeah, you do not wait for the results. You always get your sample first, even if you don't know if they have confirmed meningitis, right? Okay? If they have all of the kind of the little signs and symptoms like they do the Brzezinski's or the Kernig test, and those are positive, and they have all the malaise and the fever and all of the signs and symptoms, and they have the nuchal rigidity is kind of like the big thing. The minute that you say that you have that, doctors just pretty much freak out. Okay? Yeah. So they have all these signs and symptoms that are kind of leading them down that path. They will always give them, they'll always get the sample.
Oh, so sample first, then
Sample
antibiotics, but you're
first.
just waiting on the results. Okay, I thought it was antibiotics and then sample.
No. So you always get your sample, because what do the antibiotics do? They kind of taint that sample, right? Okay? That's not what you want. You don't want that, okay? So if you have a patient that comes in and they have all the signs and symptoms of possible meningitis, you're going to be making sure that you're running into that treatment room or wherever they're going to do those LPs, and you're right next to the physician and you're getting those samples first. Right after that, literally, you label those tubes right at the bedside, right? Never leave the bedside, so you label those tubes. I don't care how important it is. You label those tubes right then and there, and then that very minute, you go get your antibiotics and you run that stuff right through. Okay? Everybody have any questions? Okay? Okay. So sample first. It's really, really important. Oh, what about isolation? What kind of isolation would you put them under?
Droplet?
Yeah. And then they're guilty and proven otherwise, right? Okay, that's what I always say. Position for comfort, we talked about that, right? Okay, that might not necessarily be comfortable. comfortable for them if they don't like to be up, but that's what we're gonna do, okay? Because we're trying to reduce that increased intracranial pressure, right, by keeping it just at 30 degrees, okay? You're also keeping it midline too. Okay, so let's talk about the two differences, okay? Obviously with bacterial, you can get a vaccine, okay? There's prophylactic antibiotics for anybody that is exposed to bacterial meningitis. I'm not quite sure how they decide how they're gonna do prophylactic antibiotics, but it's there.
We had that last year at Acute.
Oh, you did?
Yeah, I think it was 20 of us or something were exposed to somebody who we thought was just like altered mental status.
Yeah.
But kept giving them Ativan and nothing changed. We went to bacterial meningitis and we all had to go to occupational health and get rifampin.
Oh, geez.
Yeah, it was crazy.
How long did you have to take antibiotics for?
It was actually only like 3 days, but it was just like high dose rifampin turned your pee orange.
Wow.
Yeah.
So if you had a patient that had that, what would you tell them? If they were on rifampin, you would tell them what? That could be intracranial, right? Well, they're gonna freak out,
Yeah.
right? There's another medication called Peridium, totally unrelated to this lecture, okay? But since you're starting clinicals, you'll need to know this. So if you're on, well, you could be on surgical, you could be on any floor, but Peridium and rifampin, those are the two that I know of that cause urine to be like a brain port. And it stains everything. So if you have a patient that their pee is orange, don't freak out, they might be on the medication that's making that pee orange, okay? Okay. So these are the culprits, okay, that can cause meningitis, enterovitis, ticks, West Nile, HSV, HIV, most often spread directly through respiratory secretions, okay, so coughing, nose, the whole 9 yards. You guys know that with COVID. Okay. Same thing, these are your manifestations of viral, okay? We already talked about all those. You might think that that's a typo down on the expert EV test. It's basically a test that they do to check for enterovirus, okay, and that's just what it's called. As I said earlier, we know the difference between bacterial and viral is bacterial is that much worse, okay? So viral, says it right here, is self-limiting, okay? Usually you have patients that will have about 7 days of just feeling really, really crappy, and then it stops. And usually there's no other things that could happen in the long term, okay? It is rare that you can have some long-term effects, but very, very rare. That's not gonna be anything that you guys need to be aware of. Okay, so let me make sure I got all this. Okay, so we got bacterial. We know that we treat bacterial with antibiotics, right? Viral, okay, that's what causes viral. You got a bunch of bugs, HSV, HIV, talked about the signs and symptoms. Okay, so encephalitis, this is one last thing that you got to know, okay? So basically, it's an acute inflammation of the brain. Oh, God, I hate the sight of that tick. I pulled a tick off my lab this summer. It freaked me out. Who's done that? It's just gross, right? The blood is everywhere. You just can't believe how much blood is just getting sucked up. Okay, so that's what encephalitis is. By the way, caused by measles, mumps, chickenpox, HSV, and the cytomegalovirus. That's important to know. These are your manifestations. Can be very, very non-specific, okay? They could just feel like they have a cold, okay? Fever, headache, nausea, vomiting. Things get a little bit more signs can appear on day 2 to 3, so that's when it starts to get worse. And then this is kind of, once they start having these symptoms, you're really looking at, okay, what is going on here? And that's when they start doing some testing and then all the neurological things start happening, okay? So you could have some cranial nerve palsy, so all of a sudden they have a droop on the face. They can start having seizures, tremors, personality changes, you really don't recognize them. Loss of taste and smell, I'm not gonna ask you what kind of cranial nerve that is, because we're gonna focus on 3, 4, and 6. here's your diagnostic studies for encephalitis, okay? The sooner they determine that someone has encephalitis, obviously, the better, the faster, the better outcome, okay? In terms of what you're responsible for, okay, this is what it comes down to. As a nurse, if you have a patient that has encephalitis, you're making sure that you're giving them antiviral meds. If they're having seizures, you're gonna be giving them seizure meds. Basically, you're just gonna be taking care of them, okay? With this, once again, they're not gonna be moving around a lot, so you're gonna make sure that you're preventing a lot of skin breakdown, you're encouraging fluids, pretty much anything to just kind of make them feel comfortable, okay? How does it? Please take a break for, let's do 10:10. Let's do 10:05. Let's do that, okay? And then I've got some fun stuff, so I'm gonna get you guys moving around here.